Est-ce qu'il m'entend?
Bonne journée. Je suis désolé, je ne parle pas français. I will speak in English, and I hope you will follow perfectly my conference. As you have said, the title is New Technologies for Visual Rehabilitation. I'm a professor at the University of Oviedo in Spain. And also, I'm working at the company Visionary Tool. First, acknowledgements of this talk, my sincere thanks to the Optometry Institute of Paulette-Fayette for this opportunity of sharing our experience with you. Also, I would like to thank my colleague Juan Portela, that is attending also this meeting. You can see him in the webcam. That is working in Beguira Clinic in North Spain, in Bilbao. He's my colleague in this company Visionary. And also to Teresa Calderon, that is another member of the team that is working in the public hospital of Mieres in Asturias. Me and Portela and Dr. Juan Portela developed the company Visionary Therapy Tool that is going to be cited in this talk several times because it's our main contribution to optometry and visual rehabilitation. So this talk is about visual therapy, visual rehabilitation, orthoptics, and the first point I'm gonna face is what are the antecedents? What was the technology used in orthoptics? And another question, is it still in use and why? In the 1920s, Mary Maddox opened a vision rehabilitation center in London. And since now she has been considered the first orthoptist. His father was Ernest Maddox, an ophthalmologist that had developed various instruments to investigate binocular vision. The new discipline seeks to improve the binocular state of the patient.
S'il vous plaît, Monsieur Gonzalez, on n'arrive pas à voir les slides.
I see that it's lost.
If you could share your slides, please.
Yeah. Now it's there again. So as you see, well, this new discipline, orthoptics, wanted to improve binocular state of the patient affected by symptomatic tropias or phorias through exercises that train motor and sensorial integration. Importantly, they developed several instruments, and I do believe that it's worth to say that the cinetophore, also known as Mayer ambuloscope in the United States, was the main machine, the main device that was used, and is still in use nowadays, right? And the key ideas of this introduction is that visual rehabilitation at the beginning is linked since the beginning with ophthalmology. Orthoptics and ophthalmologists worked together. And the aim of this new discipline was binocular vision, sensory and motor integration, but not only motor development or motor correction, but also sensory integration with motor skills of the visual system. And it was not only about phorias, it was also about tropias. I say this because during the first part of the 20th century, it seems that the orthoptics has been undervalued in ophthalmological practice. Amblyopia is now mostly considered to be a visual acuity deficit unequally, and binocular vision is not treated. And strabismus surgery for most professionals is a problem of a motor problem. Sensorial integration is not an outcome. Maybe Hubble and Whistle experiments in the 60s and the 70s has been interpreted too respectively, rooting concepts as the critical period and discouraging the attempts to treat amblyopia beyond occlusion, particularly in adulthood. And also, we have to say that pseudotherapies in like those syntonic therapy, for example, in the field of behavioral optometry, maybe have not helped to the image that ophthalmologists have of visual therapy. So we have lost, in some sense, some key ideas we had at the beginning. Binocular vision is lost in the treatment of amblyopia. We cannot treat amblyopia beyond the critical period. Strabismus becomes an aesthetic problem. There is not sensorial and motor integration, things that maybe have to be solved. And during the last part of the during the second part of the 20th century, and mainly during the first part of this 21st century, we have seen a new renaissance of optometry and visual therapy, thanks to a new paradigm, perceptual learning, and a great effort from several scientists like Denis Levi in the photography from the University of California, Berkeley, Robert Hess from McGill University, or by the Pediatric Eye Disease Investigator Group, the PEDIG, that have developed a huge amount of information through different scientific studies. The key of those studies is the word or the concept of perceptual learning. Perceptual learning is the improvement of perception skills after repetition of attentional demanding tasks at patient actual threshold, and is based on neuroplasticity. The key idea is to repeat, paying attention at the level of the threshold where the task is difficult for the patient. Also, we have to consider what is the task itself. Perceptual learning is not only applied to vision, can be applied to the ear, for example, right? But in vision, we have to take attention to what is the stimuli we use and what is the purpose of that stimuli. For example, if we are trying to improve visual acuity, we are going to use Gabor patches. But if we are going to train stereo acuity, we are going to use random dot stereograms. Perceptual learning also takes advantage of software. In most cases, if not in all, is based on computer programs. This is because a computer program allows us to adjust difficulty dynamically to patient visual function threshold, and also allows remote tracking of patient compliance. And that's important because, as I said, perceptual learning is based on repetition, and also the patient has to pay attention to what he's doing. It's constant demanding tasks. Gamification also improves attentional response and patients' adherence to treatment. So in some cases, if not in all, we see that this treatment seems to be a game, and this cannot be misunderstood. The treatment is not based on video games. We use the idea of video game to make the treatment possible because we have in front of us kids that low age that they need to be encouraged to the treatment. Also, hardware selection has to be is a key problem in this process. We need the hardware to be to fit the quality of the stimuli we want to represent on the screen. Sometimes user interaction with the screen is based not in a hand response to the task, but interaction with the eyes of the patient. In that case, we need an eye tracker, for example. But at the end, it's also a problem of feasibility of the price of the machine, because we want to train the patient not only at the visual center, but also at home. And this is a key problem because perceptual learning, as I said, is based on repetition, and we need the patient to work every single day. It's not a problem of a weekend or a day at the clinic working 5 hours. It's a problem of working 5 days per day, maybe half an hour per day. So we have different technologies. We have polarized light, we have shooter glasses, we have anaglyph glasses. All of them have advantages and disadvantages, but maybe the main disadvantage is the patient able to have that device at home? Anaglyph glasses maybe have the problem of crosstalk or phantom image. It's easy to see through one eye what it should be only seen by the other eye. But at the same time, anaglyph glasses are really cheap. That's why we use them. And virtual reality, well, sometimes virtual reality is just a cell phone in a helmet, right? Even in a cardboard helmet. That's not virtual reality. That's a fake, right? And virtual reality, the quality of the glasses is important because if we want to train visual acuity, well, at this point, nowadays, it's difficult to treat visual acuity till normal values due to the quality of the headsets. So it's not suitable for that purpose. Maybe it's suitable for other purposes because we have a large field of view, we have motion parallax, we have maybe built-in eye tracking systems, and well, using high quality virtual reality, we can take advantage of that technology, as I will explain later. But it's not all what we see in some advertisements that say we are using virtual reality for visual rehabilitation. Don't believe all the things you hear, because sometimes it's not true. That's not virtual reality what they are using. And using virtual reality is not necessarily the best. Maybe the best for some problems is an anaglyph glasses. Mainly virtual reality cannot be used in 99% of cases at home. That implies that we need a second technology to work at home. So the third idea I would like to introduce today is what do actual protocols for visual therapy and how effective are those visual protocols? So I will start with amblyopia treatment. All of us, we know that the actual protocol is to reject organic pathology, fault correction of refractive error under cyclopedia, and patching or penalization. But we have to also critique the outcomes of that protocol. We have to be aware of what are the results of this protocol we are using. Although a great percentage of patients do improve visual acuity thanks to refraction and patching, half of them, 50% of them, do not achieve normal visual acuity using just this protocol. Also, only 30% of patients improve stereoacuity. In cases of anisometropic amblyopia, if we are talking about strabismic amblyopia, the results are even worse. 25%, 1 per 4 patients will experiment a regression of visual acuity after successfully correct treatment. And another sentence that is important that sometimes is ignored, we cannot patch a child for more than 1 year because there is enough scientific evidence that there is a plateau time after what patching is not longer to produce any benefit. So to say this the same graphically, you see that the succeed of visual improvement is not that high of this protocol. In fact, as you see, success in a measure as normal visual acuity is just half of the patient. Success in terms of binocular vision, exterior acuity is less than 30% of patients, and consider only the easy part of amblyopia and isometropia, and success in terms of only one treatment, known regression, is also really low. It's less than 25%, as I said previously. If we analyze the strabismic amblyopia actual protocol, we find the same rates or even worse. The actual protocol includes surgery if deviation angle is bigger than, let's say, 12 diopters. So we can say that, firstly, microtropia is not treated. Secondly, if we see the results of refraction and patching alone without surgery, only 30% of cases in intermittent exotropia are solved. I have only data from intermittent exotropia for this talk. Only 30%, it means that 70% will need surgical intervention, surgery. And of those, 26% will need a second surgery. So the first one is not enough. 40% of patients will not achieve binocular vision, so the treatment becomes aesthetic. And also something that is not well known, patching, when we are talking about intermittent exotropia, there is not evidence that patching improves or solves this problem. This is the same graph we used previously, yet to strengthen the same ideas. The actual protocols, although they solve, and is what we have been using, we still have a problem. So we need to deep in new approaches of these problems in order to obtain better results. This is what I'm going to talk right now. What are the new approaches of those protocols? How can we improve those protocols to have a better results at the end? So how do we improve the protocol of amblyopia? You have there the main references of the last 15 years regarding how to use perceptual learning as next to patching or with patching to improve outcomes in the treatment of amblyopia. I've written in red that in many of those papers, we are facing the problem with adult patients. So not only in the so-called critical period. And also I've highlighted in blue that what is the strategy of perceptual learning used? Because sometimes you read in the papers binocular treatment, sometimes perceptual learning, sometimes dioptic therapy. Although there are small differences, we can talk about perceptual learning as the key idea in all of them. Those were papers from the last 15 years. Visionary, me and Juan Portela, we started with this new approach of perceptual learning 10 years, 11 years ago. And we have, both of us, we have published several papers that I'm gonna share with you regarding the outcomes of our approach. With this approach of this protocol you see on this screen, another team of researchers in Spain published in 2024 this paper about the rehabilitation of amblyopia using a digital platform. It was visionary for visual training combined with patching in children. It was a prospective study with 52 amblyopic children, where 20 children already received patching and visual refraction. For those patients where patching and visual refraction was not enough, for those patients who were refractive to that traditional approach, in this paper, 32 patients, they were included in the visual therapy plus patching group. So we had 20 patients that improved using the actual protocol, the traditional protocol, but 32 that needed the help of visual therapy. And the results of total improvement in the patching group was 18 logMAR units, and in the visual therapy plus patching group, it was much bigger, 31 logMAR units. Also, we obtained improvements in contrast sensitivity function, and also, and importantly, improvements in binocular function. In this second paper that I published with my colleague Juan Portela, and also with the ophthalmologists of the Hospital of Mérida in Spain, we included in a longitudinal study 40 amblyopic children. Also next to the critical period, let's say. And in the first phase, only patching was administered. So the only treatment was patching until they reached the plateau, 1 year. After that, there was no solution for those patients. So we applied, or we proposed, patching plus visual therapy using visionary. And we obtained further improvements in the second phase, as you see there. Moreover, depending on the effort of the patient using the platform, we obtain different rates of success of patients who were working more than 10 hours with the visual therapy program, obtain a rate of success of 72%, while patients that were not using the program with that strength obtained only 40% of success. You see here also more results, because, as I said, in phase 1, patching alone, we obtained a final mean logMAR acuity of 0.26. And in the second phase, they improved till 0.13, as you see at the left part of the slide. But we had not only amblyopia patients without ocular pathology, but in this group, there were also patients with ocular pathology, even with congenital cataracts. And in those patients, also we obtained a good improvement thanks to visual therapy plus patching. So I think those results in a public hospital using visual therapy at home mainly are really important to be considered. This is an example of the activities we use, where we use Gabor patches. You see to the left what the amblyopia eye is seeing. You see that the dog has a balloon with a patch with this direction. We see that patch with both eyes, with the left and the right eye, but only through the amblyopia eye, we see what balloons on top have a stripe with the same direction. So the stimuli is dichoptic in terms that the patch is seeing in those balloons only through the amblyopic eye, the red filter in this example. And the task of the patient is to find balloons with the same direction as the balloon that is held by the dog. So we see perfectly the balloon held by the dog because we see it with both eyes, but we have to find a balloon with the same direction, but just using the amblyopic eye. The use of Gabor patches is based on the experiments of Hubel and Wiesel. So we are targeting spatial frequencies at V1, and we are working with the contrast sensitivity function. As I said at the beginning, it's important to understand that orthoptics started not only as a motor rehabilitation, but also as a binocular rehabilitation. So in our amblyopia protocol, we always include binocular rehabilitation phase by means of stereoacuity recovery and by means of perceptual learning. We started with this approach 10 years ago with the first paper we published. This was the PhD thesis of Juan Portela and was the first prototype of Visionary. And there, in a prospective randomized double-blind study for the first time in science, we demonstrated that using a random dot format it was possible to improve stereoacuity and transfer the training towards tests that are used in the clinic, both in random dot format or in contour stereograms. Thanks to that great paper, we keep on working on that field of stereoacuity recovery. With Dennis Levi of the University of California, Berkeley, we wrote this second paper. In this case, it's just a proof of concept study with just 10 patients, but we are targeting to patients with strabismus and low to no stereoacuity. So let's say the most difficult patients. And that's why we use virtual reality. And also we obtain good results in 40 hours of treatment. And recently, just 2 months ago, we published a third paper regarding stereoacuity recovery. It's also a proof of concept study where we are targeting, again, patients out of the critical period, as it happened here, 28 years old, mean age, and range till 62 years old. And in the second paper, with the same aim, we treat patients out of the critical period with strabismus, and all of them without measurable stereoacuity, and with an intervention really short of just around 5 hours. And we obtain, again, really good results that are worth to analyze in terms of how to fit all these three papers and to design a therapy to improve binocular vision. What I've said is how we have modified the amblyopia protocol in general, mostly for anisometropic amblyopia. But what does it happen if we have strabismus? What do we add if we have strabismus? What we add is vergence therapy. How do we do that? We combine passive therapy by means of Fresnel prism over the director eye in order to obtain binocular fusion. And once we achieve binocular fusion, we combine that passive therapy, that is Fresnel prism is used all day. We combine that with orthoptics exercise using the computer. 20 minutes per day, 5 days per week, maybe 2-3 months. In this process, the target is to reduce the power of the Fresnel prism in case of microtropia to solve completely the problem and to obtain at the end measurable stereoacuity, binocular fusion, and to enlarge or improve the range of vergence of the patient. Because in cases where the deviation is bigger than, let's say, 12 diopters, we are sure that we will need surgery. But if the range and the binocular vision is stable, the surgery outcomes is going to be much better, and the probability of succeed in terms of binocular vision and not in terms of a second surgery is not going to be needed is higher. So that's our target, to solve the problem or to facilitate that thanks to surgery, we have at the end a patient with binocular vision. This is an example of exercise of vergence where we use sometimes random dot stereograms, sometimes contour stereograms. The patient can do the exercises at home, and we measure the amount of the progress of the patient remotely. And this is an example of the virtual synaptopher we have developed using high-end virtual reality goggles with an eye tracker inside. So we can give a new life to the traditional synaptopher by means of this new technology, the virtual reality and eye tracking. So we can measure and we can adjust through the virtual prism. We can adjust binocular vision in order to obtain fusion. We can adjust contrast and luminance in order to avoid suppression. And in that, once we have solved deviation and suppression scotoma, we can train the patient using exercises to recover binocular, to improve ranges of perception and also to improve depth perception. We have published this protocol in 2 papers. The first one was in 2020. It was a retrospective study, 26 subjects, 6 to 13 years old, and we demonstrated the improvement in terms of visual acuity and also in terms of stereoacuity. All of the patients at the end acquire stereoacuity. It was strabismic amblyopia with accommodative component. And more recently, we published in 2025 this second paper with 53 patients, also 7 to 7 years old, 7, 8 years old. It was also a retrospective analysis where we had patients with mixed amblyopia and strabismus. So all of them had strabismus, and even patients with eccentric fixation. The results of this protocol were really good. 87% achieved visual acuity in Logmar scale lower than 2:1. 65% of eccentric fixation problems were solved, and 81% of patients demonstrated at the end measurable stereoacuity. At the beginning, there were only 34% of patients with stereoacuity. This paper, I strongly recommend you to read it because it has a huge amount of data, but at least these 2 graphs where you see to the left the improvement in visual acuity from the base levels of visual acuity to after the therapy in the middle and 6 months after the therapy ended. So the stability of the results at 6 months. So we see that in the left graph, in dark, in black, we see all patients improvement. This is a logMAR scale, so improvements goes down. In blue, mixed amblyopia, and in red, strabismic amblyopia. So more or less, all of them achieve the same results. Maybe standard deviation is bigger for strabismic patients. But to the right, we see the same graph, but now in blue, we have central fixation, and in red, we have eccentric fixation. Eccentric fixation becomes really the problem here, because the results of that group of patients are not that good as the results of the other patients with central fixation. So eccentric fixation is something to take care, to think about when we start with a new patient. We have to be able to detect eccentric fixation because the prognosis of the treatment depends on that problem. And also the last paper I want to present here is about diplopia, so not necessarily amblyopia. In 48 subjects, pre-post pseudo-experimental study, most of them with a mean age of 62 years old. That's why we are talking about diplopia. And in this study, we have two different phases. The first phase is the traditional approach to diplopia, so it's just prism correction, that where we obtain a percentage of success of 51% with no visual therapy, but for the 49% of patients that did not achieve success in this first phase, we applied visual therapy and we obtained 65% of them. We solved the problem in 65% of those patients. So the new approach, the new protocol will solve around 75–78% of cases if we understand the protocol as a single unit, and with good results in terms of binocular vision. So those are the conclusions of this talk. It's important, and in that sense, I really appreciate the approach of this session in Argelia. It's important to join the efforts of optometry, orthoptics, and ophthalmology for the patient to improve the results of these patients. Amblyopia is not only a monocular problem, it's a binocular problem, and we have to treat amblyopia and strabismus using a binocular approach. That means that we have to use technology not only to treat the patient at the clinic, but also at home, because the new approach, perceptual learning, is based on the effort of the patient and the effort in a daily basis. The patient has to work not that much, but daily. Of course, new studies are needed, but we have scientific evidence. And well, those are the key problems the new technologies must face: compliance, home exercises, adjusting the threshold, the exercises to the threshold of the patient, attention, adherence, and if you want a final sentence, with those approaches, virtual reality has become the new cinematographer of the 21st century. That's it. Thank you for your attention. I hope you have followed my English. It's not that good. And in case you want to ask any question, me, with the help of my colleague Portela, will try to answer your doubts. Thank you very much.
Thank you very much, Professor Santiago, for this excellent presentation with curves, with bibliographic papers. And we move on to the questions and answers session. Est-ce qu'il y a des questions? Yeah.
Thank you for the presentation. Drawi Walid, orthoptist in Ibn al-Haytham Center. I would like to ask 3 questions. For better result, should strabismus be surgically corrected before initializing therapeutic rehabilitation?
Please repeat because it takes me an effort to understand.
Yeah.
Should strabismus be surgically corrected before initializing therapeutic rehabilitation?
Well, have you understood, Portela? Juan dice que si debemos corregir el estrabismo antes de.
Sí. I think that improve the outcomes of surgery.
Yeah. In order to improve the outcomes of surgery, visual rehabilitation before the surgery makes 2 things. We enlarge the range of convergence and divergence so that the practitioner will have a range where, well, you want to fix the angle here, but you have a range of error thanks to the range of binocularity acquired thanks to visual therapy by the patient. But also, we have to stabilize the angle. Because if we go to surgery without visual therapy, in most cases, the angle is not stable. So what is the angle we want to correct? If some days we have one angle, some days we have other angle. No sé si lo he explicado bien, Juan. Estabilizar el ángulo.
Sí, el plan quirúrgico se establece con el valor de los prismas en la gafa.
Right.
Sí.
So that's the idea. The surgical plan has to use an angle that has been applied to the glasses of the patient and where the deviation is stable. Right? That's why we really strongly recommend visual therapy previously to surgery.
Thanks. We have 2 more questions. Is there a risk of inducing diplopia after the treatment?
Si hay riesgo de diplopia.
No, porque hay visión binocular previa a la cirugía. Y estereopsis.
Right. There is no risk of diplopia. One factor that Juan is pointing out that we have before surgery binocular vision and moreover stereoacuity, so we cannot develop diplopia. And there is a second reason that there is always the fear when we apply visual therapy to diplopia. Diplopia happens when we have old patients. We have a younger patient, he has or she has suppression. And in case something goes wrong, he's going back to suppression very, very fast because it's what the brain of the patient has learned to do. Sí, Juan.
El tratamiento solo se prescribe en pacientes con correspondencia retiniana normal.
Yeah. Also,
normal correspondence.
Normal correspondence is recommended for this treatment. If we have anomalous correspondence, then we don't recommend the treatment, right?
It's okay. My last question. Do you have any correlation between functional gain and their visionary and neurophysiological marker of cortical plasticity that will support true interocular gain rehabilitation rather than purely behavioral learning effect.
We have not made a functional resonance or any image of the brain in our studies to support the effect within the brain of our intervention. So we don't have that level of evidence, but I should say that we don't need it. We have our intervention improves visual acuity, contrast sensitivity, and stereoacuity, and even vergence ranges, and that can be measured in clinic objectively. And we have papers where we have control groups, right? So we know that our treatment works. And when we compare this treatment with behavioral optometry, it depends on what do we understand by behavioral optometry. I said this, our approach is based on scientific papers published within the last 20, 30 years, right? Those papers for visual acuity are based on the use of frequencies by means of Gabor patches to improve contrast sensitivity function and visual acuity. Those studies are based on what we know about the brain. V1, thanks to Hebel and Wiesel, V1 neurons are synchronized with spatial frequencies. So if we want to improve visual acuity, we have to improve those neurons. So the most effective treatment is to treat group of neurons that we know that are not working well. And we know that because we can measure that in a contrast sensitivity test. So that's why our treatment is effective. Effective in terms of we don't need that much time to obtain an improvement. It goes really fast. The recovery of amblyopia in anisometropia using our approach is about 2 months. And the recovery of visual acuity in strabismic amblyopia, it depends on the angle, but it's around 3 months, right? So other approaches like syntonic therapy that I have cited in the presentation have not any scientific evidence.
Thank you.
Alors, est-ce qu'il y a d'autres questions dans la salle? Thank you, Dr. Gonzalez, for your conference. Thank you for the explanations. We hope to see you next time in Algeria physically, you and your colleague. So, thank you very much.
We will like. Thank you very much.